Join us on Healthline with Makati Med as we discuss the latest health and medical topics with doctors from Makati Med. For a healthier and uplifting lifestyle, tune into Healthline with Makati Med on 𝗛𝗲𝗏 8:10 a.m. Radio Bandido TV. You've got questions, we've got answers.
Watch and listen to Healthline with Makati Med every Monday from 5 p.m. to 6:30 p.m. Airing on Sky Cable Channel 224 and on all DTT boxes. Simulcasting online on Facebook and YouTube. Listen and watch on your mobile devices. Just search 𝗛𝗲𝗏 Radio Bandido.
You're about to experience Healthline, a show where doctors from Makati Med interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome to Healthline with Makati Med. I'm your host for this show. My name is Nicole Jacinto, and we are live from Metro Manila. It's December 11 here, but whenever you watch this show at whatever time, it may be another nighttime, daytime, in middle of the nighttime, anytime. Just keep watching it and keep watching not only this show but the other shows as well for more information on how to have a healthier and uplifting lifestyle, and also about the latest medical breakthroughs and medical procedures when it comes to taking care of your body and your health. And today with us on the show is Dr. 𝗛𝗶𝗹𝗁. Welcome to the show, Dr. De Leon. How shall I call you?
Please call me Ginny.
Okay, thank you. Thank you, Ginny, Dr. Ginny. Dr. De Leon, or Ginny, is a hematologist and a transplant specialist, which is quite provident for me since I was just in Makati Med about a week or two ago, and they told me to seek out some hematologists. But that's not the topic for today, actually. You're like, oops, napasubo. Okay. Today, we are going to talk about lymphoma. So, of course, this is a serious disease, but, whenever we can on this show, we talk about it. And, just if you want to send in any questions, send them in now while we're live so that we can answer them on the show as well. And before we talk about lymphoma, Ginny, can we talk a little bit about the lymphatic system? Just a quick we begin our discussion about, like, what's the main function of the lymphatic system, all of that stuff. Just a quick overview. Thank you.
Okay, so basically the lymphatic system is a network of organs and vessels running through the entire body. So first we have the bone marrow. The bone marrow is where all of our blood-forming cells are formed. So this is where the lymphocytes are formed. So the lymphocytes are the ones that actually travel as part of the lymphatic system. We also have the thymus, which is an organ. Initially here, this is where the T cells initially mature. And then we also have the spleen, which is an organ in the abdomen. This is where the blood cells, we actually call it the cemetery of the red blood cells and other blood cells. So this is where they die eventually when their lifespan is over. We have the blood vessels, so the lymphatic vessels that travel around the body. We have lymph nodes. So lymph nodes can be areas where lymphocytes are stored, and then these are areas where that can release the lymphocytes in response to infections. Okay. So the lymph nodes are actually the ones that get swollen when there's an infection. Sometimes if there is an obstruction somewhere along the lymphatic vessels, this may also cause an obstruction and swelling somewhere, anywhere around that area. Okay. So these are the main parts of the lymphatic system.
Thank you, doctor. So basically it's like a lot of organs and the blood itself, no? The blood's from the lymphocytes and the other types of blood, and you mentioned they're created in the bone marrow.
Yes.
And they also, like, I guess the blood carries it around. And then you mentioned the thymus gland. That's in the brain?
No, it's in the thorax, in the chest, somewhere in the chest area.
Okay. Yeah. Thank you. My God, what is happening to me? Oh, I was thinking hypothalamus. Okay, so it's in the thorax, in the chest area. So it's like really all over our body. And then when the spleen, you mentioned, I don't hear a lot about the spleen. So that's where our blood cells go to die, basically. And
Yes, 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 yes.
just like quick off the bat, no, our spleen we can live without a spleen, like in severe accidents.
Yes, there are some cases wherein there are accidents or we have to remove the spleen, and we can live without a spleen, but we need vaccinations to help prevent infections. So
Yeah.
if there is some time before a splenectomy, before the procedure, then it would be advisable to give vaccinations against certain bacteria. But yes, it is possible to live without a spleen.
Thank you, doctor. And then also, of course, the blood vessels involved and the lymph nodes. That would be in the areas like well, I guess the skin, no, is the biggest organ covering. Is the skin must be part of this as well? Because-
The skin is not actually part of the lymphatic system. But if in certain types of lymphoma, it can still be affected. So in lymphomas, it can affect any part of the body. But there is we call these extranodal areas, and the main part, which is the lymphatic system. We have lymph nodes everywhere. So in our neck, axillary area, abdomen, chest, even in our everywhere.
Everywhere,
It's about hundreds of lymph nodes all over our body.
Because like when we hear about lymph nodes, most people think, oh, it's swollen here around my neck or around the tonsils because there are lymph nodes there, or as you said, ancillary, that's like the underarm or the
Yes,
armpit area,
yes,
like
yes,
around the groin, maybe.
yes.
Okay, and
There's
then like
also some in the groin.
and then
Then some also in the chest and some in the abdomen. So the lymph nodes that get enlarged will depend on what area they drain. So for example, if you have lymph nodes in the neck, usually they drain the head part. So there's the inflammation is somewhere in the head part. If there's inflammation in the groin, then maybe it's in the abdominal area.
Yes.
So it depends on what part of the body the lymph nodes drain.
Okay. All right. Thank you, doctor, for giving a great overview of the lymphatic system, and for telling us, like, showing us that it's really like all over our body. And there may be
Yes.
certain points where we say, oh yeah, lymph nodes. No, but it's not just there around your neck or around your underarm or around your groin. As you said, there are also in the chest or abdomen and in other parts of the body as well.
Yes,
Thank you,
yes.
doctor. Because sometimes I guess like I was under the impression that the skin was part of it too, just because if you have swollen lymph nodes, like it pops up.
They're under the skin, actually. Yeah, so the skin is actually just overlying the lymph nodes.
Okay.
There are even lymph nodes that are deep inside the chest and the abdomen, so you only see them when you do imaging studies.
Oh, okay, great. Okay. I mean, that's why this it's not, you can't just simply tell, I guess. So we can circle back to that later about like how you tell when there's how you diagnose or what the signs and symptoms are. Okay, so thank you for that. And then let's get to the question of what is lymphoma actually.
Okay. So, well, basically, lymphoma is a cancer. And this cancer comes from the blood cell, which is called a lymphocyte. So when our blood cells are formed, so there are different kinds of white blood cells. We have neutrophils, lymphocytes, monocytes, eosinophils, basophils. So basically, it's the lymphocytes that are affected for lymphoma. And these lymphocytes, they can grow in the spleen. Sorry, they can grow in the lymph nodes. So sometimes any part of the body where these lymphocytes can deposit, or where they usually migrate to, can form lymphomas. So, but the most common would be in the lymph nodes. For every kind of cancer, the most common pathology would be uncontrolled growth. So they just grow by themselves, even without stimulation. So that's what happens when the lymphoma gets bigger and bigger. So it's uncontrolled growth, as in with any cancer.
So yes, with any cancer, so it's basically it's forming what you might call a tumor. Am I correct? Is that
commonly that's the common manifestation of lymphomas, but there are some lymphomas that are there are rare lymphomas that do not form tumors. but
Oh,
the more common presentation would be, yeah, tumors or masses.
okay, yes. And doctor, can you give us maybe just so what happens when you get lymphomas? Essentially, there's, as you said, with any cancer, it just keeps multiplying and multiplying. So this is like those cells would exist in your body, but there's a switch that's supposed to turn them off, or like a kill switch that says kill these cancer cells. But
Mm-hmm, mm-hmm.
it doesn't work.
Yes.
Like
That
it's
that would be in a person with a normal immune response. So in
okay.
some patients with lymphoma, their immune response is a bit deranged. So some are immunocompromised. That is one of the risk factors for patients with lymphoma.
Mhm.
Um, in usually the manifestation of lymphoma will depend on the site of
On
lymphoma.
the side of them.
So the most common would be lymph nodes in the neck. So
Okay.
enlarged lymph nodes in the neck. Other patients will have lymph nodes in the thoracic area. So
Mhm.
sometimes it may present with difficulty of breathing. So that's also a common manifestation. Also, patients can present with fever. So that's one of the lymphoma is one of the differential, one of the things we think about if there's a patient who presents with fever that is prolonged.
Mhm.
We can also, if a patient also has weight loss, so that's also one of our considerations.
Okay.
Yeah.
Yeah. Okay. So, doctor, okay, circle back to some of those things that you mentioned just now, a little
Mhm.
later. Can I ask what are the most common lymphomas, or what are the different types? If you'd like to elaborate on all of them, that's fine. Or what are the most common that you'd like to talk about? And
So yeah.
go ahead.
Okay, so first, there are actually plenty, super plenty types of lymphoma, but there are two general kinds. So we have the non-Hodgkin and the Hodgkin lymphoma. We differentiate this based on the biopsy results, based on the histopathology and the biopsy results, and they have different treatments as well. For the non-Hodgkin lymphoma, there are a lot,
Yeah.
maybe dozens of kinds of lymphomas, but the most common would be diffuse large B-cell lymphoma. Well, in the Philippines, that's the most common. We can also classify lymphomas based on their aggressiveness. So there
Mhm.
are, well, Hodgkin and diffuse large B-cell lymphoma are classified as aggressive lymphomas, but there are also lymphomas that are called indolent. So these indolent lymphomas, some indolent lymphomas, we can actually employ a watch and wait approach.
Okay.
They grow very slowly over time. So sometimes we just monitor the patient and treat as needed if they have symptoms or if there are other indications for treatment. So most common, we have diffuse large B-cell lymphoma
Okay.
in the
Diffuse
Philippines.
large B cell, B as in
Yes.
baboy.
BLBCL, yes. B as in B. That
Yeah.
that is because uh in the development of our blood cells, the lymphocyte can actually be a B cell or a T cell. And this
Okay.
is where the B cell lymphoma name comes from. So it comes from the originating cell of the malignancy.
Okay. Yeah, talk dirty to me, baby. I love it when you talk about T cells. I don't know why. So maybe you can give us the difference between a B cell and a T cell, just because that is
Well,
probably as you said, the most common in the Philippines.
mhm, mhm. Actually, there are no strict, we can't really differentiate a B cell and a T cell just based on how they look like, or
Yeah.
it's basically more of molecular characteristics. So
Okay.
when we diagnose lymphomas, we actually do additional molecular testing to
Okay.
say if this is a B cell or a T cell.
Okay.
So we usually do immunohistochemical staining on the tissue sample, or we can do flow cytometry to
Mhm.
differentiate between a B
And a T
or
cell.
a T cell. The yes, the in general, T cell lymphomas are less common. So B cells are really the more common types of lymphomas, and the treatment for non-Hodgkin lymphomas, the most common treatment would be a regimen of chemoimmunotherapy.
Okay.
For T cell, we remove the one component of that because that component specifically attacks the B cells. So the immunotherapy or the targeted therapy for treatment itself targets either the B cells or the T cells. So for now, we have B cell therapies that are available.
And those are the B cell is the most common non-Hodgkin's lymphoma. What about
Yes.
lymphoma? Can we talk a bit about that since it's divided into basically two for the purposes of our discussion, which I know have to be like more general, and get us to get people like me who are, of course, not well versed in this and not like you to kind of understand the Hodgkin's lymphoma. What's
Yes.
the difference? What's the
Okay.
basic?
So when we do the biopsy, the biopsy of Hodgkin lymphoma usually shows Reed-Sternberg cells. So these are characteristic cells in the biopsy of Hodgkin lymphoma. We don't see this in patients with non-Hodgkin lymphoma. And the treatment for Hodgkin lymphoma also differs from non-Hodgkin lymphoma. So the common regimen, there's a common regimen. It's composed of 4 drugs for Hodgkin lymphoma. And then for non-Hodgkin lymphoma, there's also 4 medicines, but it's of a different type. So for non-Hodgkin, we call this RCHOP, RCHOP. That's 5 pala, sorry. And for Hodgkin, we have 4. So we call that ABVD. The regimen is called ABVD. These chemotherapy...
ABB?
ABVD.
Sorry, ABVB for Hodgkin. Hence for non-Hodgkins, it's 5. It's RCHOP. Okay.
Yes. So, but the duration of treatment for both of these, we usually give treatment once a month. So that once a month is about once every 3 to 4 weeks, and that lasts for about 4 to 6 months for the initial therapy in general. And then we reassess after that.
Okay. So, doctor, can you tell us, like, you've already mentioned the most common type of lymphoma here in the Philippines, which is the B cell, non-Hodgkin's B cell lymphoma. And wait, before that, can we dispel is it true or is it not true? I've heard, and a lot of, like, I guess people my age have heard that Hodgkin's is less deadlier than non-Hodgkin's lymphoma. Is that true?
It really depends on how aggressive the disease is. Both are aggressive actually, and both can be fatal. But the good point here is that both are actually curable. So we can cure both of them. They're both aggressive. So if not treated, then it can be fatal.
Okay, so there's no like one is you're better off having one than the other thing.
There are a lot of other factors to consider.
Yeah. Okay. So, okay. When we talk about the B cell lymphoma that is the most common in the Philippines, is there any type of demographic that you did?
Yes. So actually, the lymphomas are more common as we grow older. With a lot of hematologic malignancies, the elderly population actually has an increased risk of getting these cancers. So not just lymphomas, also leukemias. So we see a higher incidence as we grow older. And we attribute this maybe because of the mutations that we acquire as we grow older. So these mutations may not be evident. We can't really see it. It's more of a laboratory. We only pick it up when we do laboratory testing. But this is one of the possible reasons why having these kinds of disorders is more common when you grow older. Males are also a little bit, it's also a little bit more common to see lymphomas in males than in females. I don't know why. I'm not sure why. The demographic is that there's more in males. But there are a few kinds of lymphomas that are more common in females. But in general, it's males. What else? Immune system. I keep on mentioning that if you have an impaired immune system, your risk of getting lymphoma is higher. So impaired immune system would be patients who have maybe HIV, patients who have certain infections. For example, some patients who have hepatitis are more prone to developing certain forms of lymphoma. In other
Hepatitis
countries,
A or C?
B and C, B and C.
Okay.
B
I
and
see.
C are more associated with that.
Yes.
Also, certain infections, for example, in other countries, there is this thing called HTLV1, which leads to acute T-cell leukemia lymphoma. It's more common in Japan, actually.
Oh, okay.
So, I think one of the screening measures they do is that for breastfeeding women who have HTLV1, they are not allowed to breastfeed their children so that they will not pass the virus and the children will not develop the leukemia later on. So that's one of the possible.
HTLV1 is a virus that makes your immune system, compromises your immune system. And if you have a compromised immune system, like if you would have HIV and then develop AIDS, or if you have, let's say, hepatitis B or C, as long as your immune system is compromised, it kind of makes you, I mean, it's a risk factor for
Yes, it is a risk factor for lymphoma, for certain kinds of lymphoma.
certain kinds of lymphoma. That's great that we know that, doctor. So, you know, that might be one of the things that you would like to tell us later on, like, what to watch out for and all of that. And also, okay, so what can you pinpoint a specific cause or causes? Like, what causes lymphoma, basically?
Actually, no. We don't really know exactly what is the tipping point that triggers the formation of lymphoma. It's more of an interplay of the mutations, the immune response, the other exposures. There are some chemical exposures that might also induce lymphomas. But specific cause, we really do not know yet. There is no, besides the HTLV1, we do not really have something that is causal. So if you, I can't really say, radiation, that's one that can be causal. Yung people who were exposed to the atomic bombings in the past, they really had high risks of having lymphoma. Patients who had previous chemical exposure, so some chemicals also increase the risk for lymphoma, but there is nothing that says that if you have this, then eventually you will have lymphoma. So there's really no single predictor that will say na you will have lymphoma.
Yeah. Okay. But you can find some causal links as much as possible. I mean, if you were to say this will probably give it you, or what you found so far in your research is that if you were exposed to radiation, and as you said, who were exposed to the atomic bomb, well,
yes,
Japan
very high dose radiation in the past.
Yeah, they got two bombs, one in Nagasaki, and okay, let's not go through that World War II thing, but yes, that's why it. I guess guessing that's why it might be there, and that's how the research came up. So also for certain chemicals, they exposure to certain chemicals. Like let's say if you work in a chemical plant, or
actually. Yeah, in some research, they found that there are certain professions that actually have a higher risk of developing lymphomas, and they attributed it to some of the chemical exposure. So one of the things I read was women hairdressers who were exposed to some aniline dyes. They had a higher risk of having lymphoma in the future.
Women hairdressers, so
hairdressers.
Not male
hairdressers. Yes, specifically women hairdressers. Some who were spray painters also. That was also increased. Some form of farming. I think crop farming also increased the risk. So these are, but it's not causal. It's not causal. It just increases the risk of having lymphoma because of the possible exposure to the chemicals.
Yes.
But again, it's not, it doesn't follow that if you're exposed to it, you will develop lymphoma in the future. But there are some who do.
And maybe like it's a certain type of chemical and certain types of dyes. And I mean, but that's great that the research is going on, and if you found some, like you
But
are
yeah,
likely you found some profession, so that people who are involved in these professions, who do these things, can sort of be more aware. Or people
yes.
they can be more aware. If you work in, I guess, a certain chemical plant or certain chemical plants, which gets like that's so much already, or you're exposed to chemicals, certain types of radiation. And then spray painters, that's quite interesting. Maybe it's the quality of paint, the chemicals there, plus the safety and all of that to get it to stick. So also the crop farming, because there's a lot of pesticides. Like before that,
Yes.
Malathayon, nobody knew, that Malathayon was, or maybe they did, but that's like damaging to people. Or I mean, because there are a lot of pesticides that are used for farming, to make it, of course, more economically viable and for the whole world to get fed in that sense. So those are some of the professions that you found higher incidences of developing of people developing lymphoma. No, that's okay. So at least thank you for informing us about that, doctor. That's really good to note. And it's, no, for the hairdressers, it's just the female one specifically.
Yeah.
There's a lot of people we're gonna research that, and kind of figure out why. Or I don't know, maybe the demographic is just, there's more female hairdressers, who knows. But there are a lot of male hairdressers as well, so we really don't know. But that is so interesting. So by your male hairdresser, they'll go like, okay, I'm clear. Really know where this comes from, right? But we don't know where it comes from. But as you said earlier, doctor, it's curable. If you treat it, it's curable. Lymphomas are curable.
Well, in general, there are some lymphomas that are very hard to treat, but for the more common ones like diffuse large B-cell lymphoma and Hodgkin lymphoma, these are actually curable. That doesn't necessarily mean it won't come back. There is a percentage of lymphomas that do relapse, and we have we have other treatments available for those kinds of lymphomas, but it can be treated. About maybe 50-60% of these, initially we can achieve cure for them.
Okay, doctor. We did ask about the demographics and what causes it, which is like we really don't know, but there are it's associated with certain things, and radiation basically and chemicals can really give you like.
Yeah. Also, there is an association with smoking, like all cancers. Also with obesity. So that can also, there is also an association. It's not causal, but it increases the risk for having lymphomas. So,
Okay.
yeah.
All right. Doc, we just have to take a short break, and when we get back, I'll have more questions for you. And those of you who have questions, send them in now. Send them in now. And Doctor's very fast on the ball, very informative. She's got a lot to say. So I'm glad you're a guest for today, for this topic. And just sit back, Doctor, chill out, and give us a few minutes to play some certain reminders for people out there, and to remind them about the services of Makati Medical Center and the Makati Medical Group. And we'll be right.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. Jacinto from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of Cubao. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza Tower 1 in Araneta Center, Cubao. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City. This is Dr. 𝗂𝗶𝘁𝗵 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable through Makati Med Care Access at 𝗂𝗶𝘁𝗵𝗹. Available for outpatient care services, our 𝗂𝗶𝘁𝗵𝗹 site offers consultation and diagnostic procedures such as medical assistance, hospital admission assistance, blood pressure monitoring, laboratory tests, and X-ray, among others. This is really convenient for those residing in Makati and nearby areas who do not want to go to the hospital to have these treatments and procedures done. We believe that access to excellent quality and compassionate healthcare is a basic human right, and we at Makati Med 𝗂𝗶𝘁𝗵𝗹 are doing our best to make this possible to more people. We are open from Monday to Saturday at 8 a.m. to 5 p.m. at the third floor of 𝗂𝗶𝘁𝗵𝗹 in Makati City. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Care Access 𝗂𝗂𝗶𝘁𝗵𝗹.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto, and with us today is Dr. or Ginny, as she said to call her, but Dr. 𝗂𝗶𝘶𝗵𝗹𝗁. Thank you for being on the show, Doctor. Dr. Ginny is a hematologist and a transplant specialist in Makati Medical Center, of course. And today we're talking about lymphoma. And Dr. Ginny here has given us so much information already, but if you have more questions or specific questions, do send your questions in now. And or you know, I think anyone who listens to you, doctor, will get a lot of information. It will just like listens to you and it's like we'll just be fascinated with all the information you're giving us, and it'll already, you know, as I hope, lead to one step to another for the information to get out there to the people who need to hear it. That it, you know, it causes some kind of a positive chain of reactions for people who need help, to seek out help, and especially your help. Can I ask you why? Well, you did say that, you know, it's the bone marrow. It's the basically the type of cells or blood in the bone marrow. Why is a hematologist? Does a hematologist treat lymphoma?
Yes.
Okay.
I'm sorry, I answered already.
No, that's fine. Yeah. Are you the main person? Does an oncologist with you? Like, how does that work? I mean, without talking about specifics of treatment first, but some people may wonder, oh, I'm a hematologist. Okay, so is it really like a thing that you have to take control with the blood, or
Actually, so like what I mentioned earlier, lymphomas are cancers that originate from lymphocytes, and lymphocytes are a type of blood. So Yes, basically, we do treat lymphomas, hematologists, but we also have medical oncologists who treat lymphoma. So both of our specialties can treat lymphomas. Besides us, we also have other colleagues. For example, what I mentioned earlier, it depends on the site of lymphoma. So if the lymphoma is in the head and neck area, we have ENT specialists. If they're in the gastrointestinal tract, we have gastroenterologists who help us. If they're in the lungs, then we also have pulmonologists. We also need surgeons who do the biopsies, also ENTs, sometimes interventional radiologists if the lesions are deep inside. So we also seek their help. So it's really a multi-specialty approach in treating lymphomas. As with a lot of cancers, we actually want a multidisciplinary team handling these cases. So all bases are covered.
Yes, thank you, doctor. And you have mentioned like it depends on the site of the lymphoma. Is it always associated with a site in the body, or could it be sites or
Yes, it actually, that is where staging comes in.
Okay.
So if you have stage 1, then it's a limited area, so it's just one area. If you have stage 2, maybe there are 2 areas. We look at the diaphragm, so that's the area between the abdomen and the chest. So if it's just one side, just up, then it's stage 2. If you have both up and down, it's stage 3. And if you have sites all over the body or extranodal, not in the lymph nodes, then that's stage 4. So it can vary. It can be just one site, it can be multiple sites. And the treatment also varies depending on that.
Yes, doctor. Thank you, doctor. And then before I ask you what the site okay, so basically I guess this kind of goes in line with like what are the signs and symptoms that you should be looking out for or that are most associated with having any type of lymphoma or a certain type of lymphoma. I mean, you can give us general symptoms or you can, pair one with the other, whatever's most comfortable for you. Also, like, if you give us the signs and symptoms after that, if you could maybe just talk a bit like how having lymphoma impacts the lymphatic system, and that's why you're feeling like this is the same.
Okay, so
Thank you. I'm very chatty.
so the most common really would be lymph nodes, so swollen lymph nodes, and most common would be in the neck area. So if you have swollen lymph nodes in the neck area, that can cause some obstruction in the lymphatic system. So it can cause usually it's a painless swelling of your lymph nodes. So if it's painful, it usually points to an inflammation or infection. So if it's swollen, then it can cause some obstruction in the lymphatic system. The lymph nodes are enlarged, so that can cause some. Okay, again, it depends on the site. But if your lymph nodes are enlarged on the neck, some patients would feel, if it's near the front, there would be compressive symptoms. So difficulty in breathing, difficulty in swallowing. Some patients, if the size is already very big, then that already constitutes an emergency because they will not be able to eat or they will not be able to drink. So that would be advanced stage already. So we need to treat that immediately. Other presentations would be, again, tumors. So tumors in the chest area that would cause, again, obstruction in the breathing. So that would lead to difficulty of breathing. Sometimes, if the obstructions are very big, they can surround or encase one of the big blood vessels that come from the heart. So when that happens, that is again another medical emergency. It causes difficulty of breathing in the patient, and we need to give treatment immediately for cases like that. Some would have tumors in the abdomen, in the gastrointestinal tract. So if they have tumors there can be gastrointestinal bleeding. So there can be some bleeding in the stools. There can be, they can vomit some blood. So that will cause anemia, a decrease in the blood counts. They will feel fatigued when they have low hemoglobin. So they will, and again, the difficulty in eating, pain in the area. So those are the manifestations coming from that tumor. patients may also have fever. So the fever, there is the thing called B symptoms for lymphoma. So it's fever, weight loss, and night sweats. So we usually ask our patients if they have any of these symptoms. Just because they are pretty common in lymphoma, and they have some significance in patients with Hodgkin lymphoma. So they can, if they have these symptoms again after they have treatment, then it can herald a recurrence of the disease. But fever, so we have to check if there's fever. Usually it's a temperature of 38.3 and above for at least 3 days. There should be, well, the weight loss is qualified as 10% weight loss in the past 6 months, and then drenching night sweats. So this is one question I ask my patients. When you sleep at night, does it get very hot that you have to remove? Do you sweat so much that you have to change your clothes? So that's what drenching night sweats means. One peculiar symptom with Hodgkin lymphoma is that the lymph nodes actually get painful when they drink alcohol. So when they drink like wine or beer, the lymph nodes get painful. So that's also something peculiar. But if that happens in the future after the treatment is finished, then it may also herald that the disease is coming back. So those are one of the symptoms. Fever, weight loss, and fatigue. So fatigue is very non-specific, but it's very, very common in these patients.
Yeah.
So yeah. Masses, any masses, fever, weight loss, night sweats, fatigue, and then the site-specific symptoms already.
Thank you for doctor. It's just amazing. Like, boom, you read.
Sorry.
No, don't be sorry, please, because my mind tends to like fly in all directions and work really fast, and I'll ask you like that 10 questions at the same time, as you can ask your fellow doctors who have been in the show. They're like, magulo talaga tong babae na to. But you just answered it already without me, I was just starting to think it, you answered it. Thank you for being very specific about like the fever should be 38.3 and above for at least 3 days. And then also, and this could be recurrent, no? Like maybe you had it
Yes.
for, and you're like, okay, but you kind of keep getting that. And
Yes.
and then so you're laid up in bed with fever of 38.3 and above for more than 3 days at a time. And then fatigue, as you said, is non-specific, but everyone knows what it feels like to just feel so tired, exhausted, and maybe your bones hurt in some places, but it's not really the bone pain, it's something else. And then 10% weight loss, great, that's really specific. Over the last 6 months, though, you said. Yeah. And then the drenching night sweats, meaning like you're really like you start feeling really hot at night when you're sleeping and taking off your clothes, or like it's like when you have, it's like almost like when you get a bout of high fever or some or infection like the flu before. And if you've ever been in the hospital or not in the hospital, but you shake, and then we didn't say shaking, but what I mean is there are times when you shake, and then afterwards suddenly you feel so cold, and then you're shaking, and then you have to change your clothes 3 times, or like it's on your bed. So that would be the things
Yes.
you would ask your patients. And the peculiar thing that you mentioned about when you drink alcohol, your lymph nodes tend to
Get
hurt.
painful. Yes.
I just want
Although
to
none of my patients have had that. It's just something that's in the books, but
Yeah.
I really haven't encountered that in real life.
yes. Well, now that it's the holiday and partying season, don't go around testing that you're like, oh, I'm gonna drink more. I have, if I feel like it hurts or whatever it is, don't go around using that as an excuse to check that theory. But yeah, something maybe you haven't encountered it with your specific set of patients, but it's been found elsewhere.
Yes.
Okay, great, doctor. Thank you for answering all those questions. And so if these are the symptoms that you look out for, and then of course, as you said, on site, and you did mention like usually if lymph nodes are obstructed, like in the neck, you said again depends on the area, the neck and above, it's painless. I mean,
Usually the lymph nodes are painless. Yes.
nodes are painless.
They're rubbery and painless. So it's one of the, well, although it's not 100% painless. But more commonly, lymph nodes from lymphoma are painless, while lymph nodes from infection or other types of inflammation are painful.
But in the abdominal area or other areas, there can be pain, and that would
Mm.
be a symptom. Okay.
The lymph nodes in that area are actually deep inside, so it might not be painful. The ones that might be more painful are if there is obstruction already. So that is the one that will be causing the pain, obstruction to the other organs, versus the lymph node itself. So it's the compressive symptoms that are causing the pain in that area.
The lymph nodes are obstructed and they're swelling and they're pushing against other organs or other
Yes.
parts of the body already. So that pain might be an indicator of that. When like, I don't know why it always hurts, and then I'm pooing blood or something like that, or vomiting blood. So you better check it out. It's
But it's not really a common lymphoma. It can be, there are a lot of other differentials for bleeding in the abdomen, but that can be a manifestation of lymphoma as well.
okay.
So yeah. So better to have it checked. Of course, if there's any bleeding, then better to have it checked, whether it's lymphoma or not.
I mean, you could be you can have bleeding from dengue, but certain there are other things that can cause it, or so many other things. But basically, or maybe you think it's bleeding, but you just ate a whole lot of beets and a lot of coffee, right? So is go see your doctor. But these are some of the things that you can tell. And when a doctor like yourself takes the lead and puts it all together, then you can start actually testing. And how do you diagnose lymphoma?
Okay, so basically we need a tissue biopsy. We need to do a biopsy of whatever is affected to diagnose lymphoma. So that will give us a confirmation of what the type of lymphoma is. So on the tissue biopsy, we do histopathology, meaning the pathologist looks at the slides under the microscope and tells us what he thinks based on what it looks like. There is a second test, which we call immunohistochemical staining. So there are certain stains that react differently depending on what the tissue has. So for example, it's B cell. B cell lymphomas would usually be, these are called clusters of differentiation, but let's call it maybe flags or markers that are present on the cell. So for B cells, commonly it's CD20. So when we stain for CD20, the tissue biopsy usually has a bright brown color. So a lot of it is brown. There are other markers that we test. We also test for T cells, so that's CD3, CD5, and other markers for B cells. And it depends on the pattern of these markers on what the it will confirm the histology. It is done in partnership with the reading of the pathologist to tell us what exactly is this type of lymphoma. So the staining can be a set of maybe 5 stains, but depending on the type of or subtype of lymphoma, it can be as much as 20 stains per sample. So it will slowly differentiate exactly what type of lymphoma it is. So there, number 2. And then we also have some other molecular characteristics. So we call this FISH testing, fluorescence in situ hybridization. There are some FISH patterns that are characteristic for some certain forms of lymphoma. And there are some certain FISH characteristics that when present, give it a poorer prognosis. So for example, TP53 mutation, these are poor prognostic markers, and it sometimes tells us that the lymphoma is a little bit more aggressive. So if we have these markers, we have to be a little bit, we have to monitor a little bit more frequently, maybe be on the lookout for symptoms after we do the treatment. So these lymphomas tend to either they don't respond as well to the initial chemotherapy, or they relapse earlier, or there is recurrence. It's more common to have recurrence from these kinds of lymphomas.
Mhm.
So histopath, molecular, FISH, and imaging. So imaging is very, very important because this helps us stage the lymphoma. The more common for certain kinds of lymphoma, we use a PET scan, so a PET CT scan. But some other lymphomas, we can just do a CT scan. So it depends on the type of lymphoma. So this helps us say how many or which areas of the body are involved with the lymphoma. So we usually do the imaging at the beginning before we give any treatment.
Okay.
And then we do blood tests, the usual CBC chemistries, to see also if there are any adverse prognostic markers and if we need to treat anything before we start chemotherapy. So if there are things that we need to correct, we have to correct them first. If there are certain infections that are present, then we have to give some medications to help prevent the infections from going full-blown when we give the chemotherapy.
Okay, doctor. Okay, so a few questions for you. You mentioned about I guess 5 or 6 ways of diagnosing, how to get the real diagnosis of lymphoma or any type of lymphoma. One, the histopathology. So
Yes.
that is, of course, you mentioned tissue biopsy. Can I ask, is it always a tissue biopsy? Do you have to get it from, like, if you suspect it's very deep within, do you have to get a tissue from that part, or like is there a type of lymphoma that's just the blood and you just need the part of the blood, or you always have to do a tissue as well? Okay, and then the molecular
Yes.
is where you do the stains. It could be anywhere
Yes.
from 5 to 20 stains, and then you, in conjunction with the histopathology, you look at this, and that helps you determine, like, okay, it's probably this kind of lymphoma. And then you have the FISH, that's just a fluorescent, I guess. Sorry,
In
how?
situ hybridization, FISH.
Okay, so then that one also shows you, like, how certain types of cells are are these cells are responding,
These
or
are the FISH actually tests for chromosomes in our body.
okay.
So when these chromosomes have certain mutations, they may tell us that this lymphoma is a little bit more aggressive than the usual standard lymphomas. So we should be a little more aggressive in either the treatment or the monitoring process as well. So there are also some mutations that when present, you can opt to use other medications that may target those mutations if that is available.
All right, and then of course there's the imaging, which is like either PET CT scans, or the PET CT scans, and blood. You also blood tests. Of course, you have to take that.
Yes.
Okay, and then
Yes.
you did mention earlier, if there are any infections present in the body, then you have to deal with that first,
Mm-hmm.
and treat the infection before you start the medication or the regimen or whatever the treatment for lymphoma is. Before I ask you, like, how do you usually treat the lymphoma, and you can, just give us a couple of examples, if it's you have this way of breaking down things really well, and you got me going. I'm on my I gotta. Phew, okay, this is great. I love it. You're really making me think, and I hope that the information really gets to people who need it, and that it starts a positive ripple. And everything on the show is about helping people have a healthier lifestyle, and we have to turn to medical when it comes to that. I mean, it's not just medical stuff for the body. I know there's, and I'll ask you about it, like, there's mental health issues as well, or other issues that have to do with wellness. But for that, well, we have time anyway to talk about that later. I'd like to ask you about mutations. You always
Mm-hmm.
mutations. So as we age, there are mutations that are ongoing in our body.
Yes. It's hard to pinpoint these mutations, it's also hard to detect them. We don't routinely check for these mutations. And sometimes in the Philippines, we don't even have the capacity to check for these mutations. So these mutations are studied well abroad because they have the available technology to do that. So most of this information is theoretical, not really studied on Filipino patients, mostly on international patients or international studies that try to determine how these lymphomas come about. So there are certain mutations. For example, there are translocations for lymphomas. For example, translocation 1416. This can be attributed to a particular lymphoma. So the part of chromosome 14 transfers to chromosome 16, part of chromosome 16 transfers to chromosome 14, and then that causes causes the lymphoma. So
The chromosomes which we thought we were born with and they stayed that way already, they are missing.
they did okay, so they don't actually stay that way forever. So sometimes we are some of these mutations, we're not sure if you've had them for a long time. And we're not sure if these mutations just happened recently because of exposure to certain chemicals. But there are some mutations that when present, they actually aid in the diagnosis of certain lymphomas. So if it does not have this particular mutation, it's most likely not this lymphoma. But we don't know if this lymphoma is, if this mutation is something new, or if this mutation was already there and there are other things that led to the formation of the lymphoma. For example, exposure to this particular chemical, and then that is what led to the formation of the lymphoma itself. Yeah, so there are a lot of kinds of mutations, not just for the fish. There are also in the human genome, there are a lot of small nucleotides that can be changed. So we don't really have the capacity for that. But as we age, it's general that as we age, we really acquire more mutations. And that is what causes, for some of the hematologic malignancies, that is what pushes the patient to develop the malignancies. But specifically, there's no specific one type of mutation that if I have this, then I will have the lymphoma. So it's not really a particular mutation. It's more of the sequence of mutations. It's more of one mutation happening. It should be followed by this specific mutation and then followed by another mutation. It cannot be that the other mutation occurs first. So it's very, very complicated. It's actually very complicated.
It sounds like we're all into X-Men. Like I will now become Phoenix and the other, right? The difference.
Actually, yeah.
This is like
That is where the future of well, for hematology, we are in the molecular stage and the submolecular stage already. So that is what we are studying, and even the treatments are already targeted towards that area. So unfortunately, sometimes the Philippines, we cannot keep up with the other countries that have these technologies. So we only have theoretical knowledge of it.
Yes. Well, at least you have the theoretical knowledge and can somehow work there. If we never adapt either, which is like, I guess our body's mutating, adaptation or changing, then if we never adopt either our mindset or our knowledge or our practices, then we'll just fall way behind, like even more way behind. And okay, just before I take another short break and then we get back on and ask you more questions. For some people who are watching or viewing, I think they break it down into general terms for them. Like, is it genetic or environmental or both?
When you say genetic, it does not necessarily mean it's hereditary.
Okay.
So genetic means that there are some mutations in our chromosomes that can lead to it. So yes, it's genetic. Not necessarily hereditary. So it doesn't necessarily mean your dad has lymphoma, you will have lymphoma. But there are actually familial associations. So there are some like cousins who have lymphomas. So that can also happen. But it does not follow that if your father has lymphoma, you will also have lymphoma.
Okay.
So there is a familial association. It's genetic, meaning the chromosomes are affected. There are mutations in the chromosomes. And environmental, definitely environmental. Exposure to chemicals, exposure to infections, and we don't exactly know yet which mutation, which exposure, but it is an interplay of both genetics and the environment.
Thank you, doctor. Okay, folks, we're gonna take a short break. Doctor, we'll just take a short break. We'll be right back. Stay tuned to Helpline with Makati Med.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗂𝗶𝘁𝗵𝗶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable via Makati Med Mobile Care Access. As the name suggests, this service is mobile, which means that we go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on your needs. We can go to any location of your choice within the metro and readily offer these healthcare services to communities or groups. For added convenience, different modes of payment are available, including HMO benefits for those with a valid letter of authorization. We believe that access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For inquiries, scheduling, or pre-registration, you may reach out to us at the following numbers. We look forward to coming to you and serving your community with Makati Med Mobile Care Access. Hi, this is Dr. 𝗂𝗶𝘁𝗵𝗶 and welcome to Makati Med Wellness Center. Located at Ayala North Exchange, the Makati Med Wellness Center is a warm and comfortable state-of-the-art lifestyle center where executive checkups and services that address holistic patient care and wellness can be done. We have a skin and laser hub, diagnostic imaging, health screening, mind and wellness care, and physical medicine and rehabilitation. The Wellness Center is equipped with modern facilities and staffed with competent healthcare professionals who are committed to deliver premium, personalized, and easy access healthcare services for both adult and pediatric patients alike. This is a great place to prioritize your health and well-being without having to be at the hospital setting. We are open from Monday to Saturday at 7 a.m. to 5 p.m. at the 7th floor of Ayala North Exchange, Tower 1 in Makati City. It is also accessible from the Makati Med Hospital through a bridgeway to Ayala North Exchange. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Wellness Center.
You're back with Healthline, keeping you healthy. Moderated by Nicole Jacinto.
Okay, welcome back to Helpline with Makati Med. I'm your host, Nicole Jacinto. We are here with the amazing and brilliant Dr. 𝗂𝗶𝗁𝗏 or Dr. 𝗂𝗶𝗁𝗏, and she is a hematologist and transplant specialist in Makati Medical Center, of course. I almost said Makati Medical Clinic for some reason because I was trying to say you should really check out, and well, if she's accepting patients, and you need a hematologist or whatever it is, I would suggest you line up in her clinic. Okay. Thank you, doctor. So we are talking about lymphoma. You've given us a lot of very useful and up-to-date information about lymphoma, the most common kind, the demographics, the most common kind, at least that you find here, the demographics. Certainly some great background information on, what's going on in the rest of the world, the maybe the societies or countries that are more advanced in digging deep into the research, that have the equipment to tell. You've answered the question, like, yes, it's genetic in the sense that your chromosomes or there are mutations, but it's not hereditary, although it is familial. And I just like to remind the listeners and viewers out there that when it's familial, that means it can be found in, like, you have other family members who have it, but it's mostly you would say, doctor, an environmental thing, like something triggered it to just come out. And I love the phrase you used earlier. You're talking about your immune system being deranged. I mean, that pretty much describes how it feels sometimes, even if you have a simple thing like, allergy or some other reaction, and there's like, oh, because your immune system's this or that. You're like, yes, it does feel like it's deranged, and it's bringing me along with it on its ride. But okay, so doctor, in terms of treating lymphoma, if it's Hodgkin's, how do you already mentioned that there are four things can you get into that a little bit?
So, well, the common treatment for Hodgkin will be chemotherapy. So the chemotherapy regimen consists of 4 drugs. This is the standard traditional approach. So we give 4 drugs. A stands for adriamycin. It's commonly called doxorubicin. It's a common chemotherapy drug. B is called bleomycin. V is vinblastine. And D is the carbazine. So we give these 4 drugs usually every 2 weeks. So we give it every 2 weeks, and then we give around 4 to 8 cycles, depending on the response of the patient. So if it also depends on the stage of the patient. So if the patient has early stage, then we might opt to give less cycles of chemotherapy. There is also an option. We usually do an interim PET scan. So in the middle of the recommended cycles of chemotherapy, we do a PET scan to see if there is significant improvement from the initial scan. And if it is significantly improved, then we can just continue with the regimen, or depending on that, if we need to give any additional treatment, for example, radiotherapy. So some patients will need radiotherapy, especially those who are very, very big. For example, Hodgkin, it may present with a mediastinal mass, or a mass in the thoracic area. If that's very big, sometimes we give additional radiotherapy, or sometimes at the very beginning, before we can even give chemotherapy, if the mass is already compressing some of the areas, for example, a blood vessel, if it's compressing the blood vessel, it causes difficulty of breathing and other symptoms, we can already give radiotherapy to try to decrease the mass before we actually do chemotherapy. So we can do chemotherapy, radiotherapy. For the Hodgkin, so usually Hodgkin is curable. At least 50% would be curable. But there are cases that relapse. And when we relapse, there are other treatment options. We give another course of chemotherapy. So that's a salvage chemotherapy. We can give stem cell transplantation. So that's hematopoietic stem cell transplant. And in other countries, for other lymphomas, we can give CAR T cell therapy. This is more common for the diffuse large B-cell lymphoma. Okay, so for diffuse large B-cell lymphoma, again, it's chemotherapy. For diffuse large B-cell lymphoma, so this is a B-cell lymphoma, and it usually has one of the markers that I was talking about, CD20. So CD20, we have a medicine that acts on the CD20, it binds on the CD20, so we call this rituximab, and this is the R-CHOP regimen already for the non-Hodgkin lymphoma. For the R-CHOP regimen, we also have 4 additional medicines. So one is a steroid. It's called prednisone. We also have 𝗛𝗏𝗶, which was also in the ABVD regimen. We have cyclophosphamide and vincristine. So these are the medicines that we give. So it's also cycles. We also give it in cycles. So in the R-CHOP is usually given every 21 days for about 6 cycles. And then at the end of every treatment, either Hodgkin or non-Hodgkin, we do a PET scan or an imaging to check if it has resolved. So one of the things that we look at in the PET scan is how the lesions light up. So we call this a Deauville scoring, and it depends on this scoring if it looks like the lymphoma is already inactive or if it is still active. So this is how we usually do the treatment.
When it lights up in terms of this imaging, if you see a lot of lights, that's bad.
Yes.
If you don't see a lot of lights, then that's better.
Yes. Yeah. Because if it lights up, it means the disease is metabolically active. So that means the lymphoma is still present. So we don't want that.
So do you use a certain dye or radio?
There is a dye that is used for the PET scan, but that's the radiologists already who do that.
Yeah. Okay. So doctor, just for me to understand it better and go through it, you do therapy, and if it's Hodgkin's, you do about 48 cycles. When you talk and you give basically 4 types of medicines. This is chemotherapy. How do you give it to the patient?
Intravenously.
Okay.
Yes.
So this is where the patient goes to the hospital and sits in a comfortable chair and they receive it. Okay.
Yes.
Then are there any, or what are the side effects for, there's different types of chemotherapies, I'm assuming. So we sometimes think automatically a patient may feel nauseous or whatever. Is that also?
Yes.
Okay.
Yes. So this chemotherapy can be given either as inpatient or outpatient. It doesn't take the whole day to do it, so they can do it as outpatient. The more common side effects would be nausea, vomiting, fatigue. So these are common ones. There are rare side effects. So there can be associated lung injury with some of the medicines that we use. Some of the medicines can also cause neuropathies, meaning pins and needle sensation, difficulty in holding on to objects. So some can have that side effect, but these are not very common. Mostly it's really the nausea and the vomiting and the fatigue.
Okay, nausea. And then for the radio
therapy, yes.
That is like just not just, but sort of putting the area or an area under an X-ray like type of machine and just radiating it at a certain time every day, something like that.
It's more of like a CT machine, like a CT scan, but radiation. And the patient goes through there. It's usually it's just at a particular site, and they do it. It depends on the regimen, but it can be done every day. So this can actually also be done outpatient as well.
I'm sorry, a CT scan pala is not. I said you go in. That would be more of an MRI. A CT scan is like, it's not as claustrophobic, no?
Yeah. But it's still, there's radiation.
It's bigger.
Yeah.
In terms of claustrophobia, some people get claustrophobic inside the MRI. Okay. And then when it comes to the non-Hodgkin's, you gave us the R-CHOP, which is, and it's amazing, steroid. You give a steroid, which is prednisone, which a lot of people would, you can get a dose of it over the counter for allergy or something like that. So
really,
it's
not supposed to.
Maybe it's prednisone 10 milligrams is like for allergy, but prednisone, it's pretty much the same thing. But I'm sure you're giving it in conjunction with these other things. Is it to reduce swelling of any kind, or maybe it works with the rest of the meds too? It's a concoction always, so it works.
Yes. It works with each other. But prednisone, it actually is lympholytic, meaning it destroys the lymphocytes. So it's before that as well. Also to decrease inflammation in the specific areas. So that's why we also give the steroid. In some cases that I can't give.
Yes.
So in patients with lymphoma, you suspect lymphoma, you actually don't want to give them steroids before you do a biopsy unless it's an emergency, because giving steroids can actually alter what the histopathology would look like. So as much as possible, if you can hold off giving the steroids to the patients, then don't give them. But if there are emergencies, for example, there is difficulty of breathing, there is obstruction of whatever airway, then definitely give the steroids and then just analyze later on.
And with lymphoma, with other cancers, they will say sometimes the surgery is done first to remove masses or whatever it is. Does that happen with lymphoma as well before a treatment starts? I know you mentioned that sometimes you will do the radioactive
Radiotherapy, yes.
first to kind of bring down the size, because it's already giving the patient with lymphoma difficulty in breathing and causing other things. Do you ever do surgery also with lymphoma? Does that become necessary with certain types of lymphoma?
Not really. Well, lymphomas in general, they are very they are very treatable with chemotherapy. So we usually give chemotherapy. So surgery is not really part of the regimen unless there are some emergency situations. So your surgery is usually done to get a biopsy. We usually, if it's a lymphoma, we want the whole lymph node to be excised. If not a whole lymph node, we want a big tissue. That is because we look at the architecture itself of the lymph node. So if we just do a fine needle, then that destroys the architecture of the cell. So all you get are flat fluid. So basically, that is where surgery comes in to get our biopsies. But as part of a regimen for treatment, not really, unless there are already obstructive symptoms or if there is an emergency situation.
In terms of treating cancer, are there lymphomas where you also give gene therapy? I know stem cell and gene therapy. Okay, let's start with the stem cell, because stem cell does not always work for all lymphomas. No, it's specific to some.
Okay, so stem cell, we call this bone marrow transplant or hematopoietic stem cell transplant. And in patients with lymphoma, there are two kinds of transplant. There are two kinds of stem cell transplant. It's autologous and allogeneic. Autologous meaning we get the stem cells from the patient themselves, and then allogeneic meaning we get a donor to donate the stem cells. So for lymphomas, in general, stem cell therapy is part of treatment for relapsed cases. So if you have a patient who underwent treatment before and it was resolved and then the lymphoma comes back, we want to give chemotherapy first to see if the patient is responsive to the chemotherapy, and then we do a consolidation with the stem cell transplant. So usually this is an autologous transplant. We want to see first if the patient will respond to the chemotherapy, because if the patient does not respond to the chemotherapy, chances are he will not respond to the transplant. Or if he responds to the transplant, the lymphoma will come back very quickly. So we want as much as possible before we do the transplant, the disease is a little bit controlled already. So this is the common route in patients with lymphoma. There is this thing called a CAR-T cell therapy. So a CAR-T cell therapy is when it takes advantage of the immune system of the patient to fight the patient's lymphoma. Basically, that's what it does. So we harvest T cells from the patient, and then these T cells are engineered in a laboratory to express a certain marker that when you give it back to the patient, it will attack the lymphoma cells. So that's CAR T-cell therapy. And CAR T-cell therapy is recommended for lymphoma patients, well, B-cell lymphoma patients who relapse less than 1 year after their initial treatment. Because this means if they relapse that early, then this is a very, very aggressive malignancy. So the CAR T-cell therapy is something that is very, very recent. And we actually don't have that yet in the Philippines. No, it's not yet routine to have it in the Philippines. So usually, but in other countries, it's already standard of care. So that's one treatment that can be done for relapsed cases. So usually we use these treatments in relapsed cases already, not as frontline for lymphoma patients.
I just wanted to kind of make that clear. And when you're talking about transplant, that of bone marrow or getting the CAR T cells and do and engineering them to come in the T cells and then like telling them to attack the lymphocytes. This falls under what people think is just stem cell, like in quote.
The CAR T-cell therapy is technically not stem cell transplant. It's more of immune therapy. It's more of immune-directed therapy. But yeah, cell therapy. That's called cell therapy.
Like lay people, right? So I mean, we don't get it. So we just automatically think, there's stem cell for everything. We just that way. Not being doctors, we think that way, and it's not always. Been finding out lately, it doesn't work that way. It's not always advisable. Like it's specific too, and you have different ways of going about it. So the very common for us non-medical professionals to just like mislabel and then have mixed up ideas. And by the way, we have so many questions for you here, doctor. But just to stay there, folks. Before I ask your questions, I have one more question about for doctor. Do you do gene therapy when it comes to lymphoma?
No, it's not.
Any
Sorry.
Type, and like any type of lymphoma, you don't do gene therapy.
We actually we cannot. We are not capable of gene therapy at present. But it's not. The recommendations are still immunotherapy, chemotherapy, radiation, and CAR T-cell. So gene therapy, not really. More for inherited disorders, actually, the gene therapy.
So like taking an oral medication that is actually a gene therapy drug would not work for a lymphoma, basically. For a lymphoma.
The treatment for lymphoma is actually very targeted. We're focusing more on targeted therapy.
You can't just like shut off genes that way, or no, because there was a case of somebody asked me a question. I was like, okay, I'll ask the doctor when it is appropriate. Sometimes people just ask me questions because they associate me with the show and being able to talk to doctors a lot. So I said, okay, I will ask the doctor, and miraculously enough, you're here. Okay, doctor, you have some questions from our listeners and viewers. Is there any type of lymphoma that cannot be cured from 𝗪𝗛 AC-AR? AC is not my handwriting. AC-AR. Thank you for 𝗪𝗛 AR.
Wow, that's a very hard question to answer. I would like to say that there is treatment. There are treatments available for lymphomas, but there are some lymphomas that are really, really very difficult to treat. I'm not gonna say that there are untreatable lymphomas, but there are lymphomas that really it's difficult because of the rarity of the lymphoma. We do not have enough recommendations. We do not have enough studies to say what is the optimal treatment for this kind of lymphoma. So there are some that are like that. So I can't say that every lymphoma, but I can't say that, it's not treatable at all. We can still try, depending on what is available to us.
And that's ironic, no, Doc? The more often it occurs, the more we learn about it. But at the same time, there's collateral damage along the way. Yeah. Okay. Thank you for that question, 𝗪𝗛 AR. And then Oh, good afternoon, Nicole. G-san. Hey, G, thank you very much. G-san, please share this on your Facebook. And it's also good afternoon to you, doctor. For thank you for tuning into Health Line with Makati Med. Okay. For a question from Jessica, what do doctors do if they suspect lymphoma? I mean, maybe if,
Mm.
let's say not you and it's not you yet, like, do they recommend to you? Great question, Jessica.
Again, it's site specific. So it depends on where your symptoms are. If you have lymph nodes, and it doesn't go away with the standard antibiotic, if it's persistent, then maybe your doctor will recommend a biopsy for that already. If you have you've been coughing for a long time, then maybe we need to do imaging studies. And based on the imaging studies, they will have an impression if there is a mass, then biopsy is really the next step. So usually that's how it is. The
Okay.
first thing that you really need to do is to do a biopsy of whatever is the affected area. So if we suspect lymphoma, then we ask for a biopsy.
Okay. I'm like, wait, just a little bit more time because there are questions here. Okay. And then which lymphoma, from a question from Ia, which lymphoma is hardest to diagnose? I guess in terms, like you have to go through so many rigorous tests to make sure that that's it, or it's
It depends. Okay, so there are a lot of kinds of lymphoma. There is something called vascular lymphoma. That is a lymphoma of the blood vessels. So it's really, really very difficult to think of it at the outset because it's so rare, and you only get a diagnosis when you do a biopsy of the blood vessel. So in terms of index of suspicion for that disorder, it's very rare. So most likely you won't think that it will be this disorder. So sometimes it's a late diagnosis. You have the T-cell lymphomas, the rare T-cell lymphomas, and the rare B-cell lymphomas. You have a whole list of immunohistochemical tests that you need to do. So that would be about 20 stains. It would be easy to get the biopsy, but it would be difficult to diagnose because of the many tests, the many stains that you need to do. There are some CNS lymphomas, brain lymphomas that you have to get a biopsy. So that would also be difficult to diagnose. So maybe the areas that are hard to biopsy will be difficult to diagnose. I've also had some cases wherein it showed a different kind of lymphoma in one site and a different kind of lymphoma in another site. So what we do there is we usually treat the more aggressive lymphoma.
okay.
Yeah.
Like you can't do it at the same time.
That would expose the patient to a lot of chemotherapeutic medicines, and we, as much as possible, we don't want to give too much because chemotherapy all medicines have side effects, and eventually these side effects, it may not affect the patient now, but later on it may manifest. So there are some patients who develop myelodysplastic syndromes. These are another kind of blood disorders when they have been exposed to chemotherapy in the past. Usually the more intensive chemotherapy already targets the less aggressive malignancy as well. So we usually target the more aggressive one.
Thank you, doctor. Great answer to a great question. Which one would be the most difficult, or I guess most to diagnose? How long can you live with lymphoma? Quick question from Christine Legaspi. I guess
That will depend on the type of lymphoma because there are indolent ones and there are aggressive ones. So indolent lymphomas, 5 years, 10 years without treatment, as long as you monitor and there are no indications for treatment, it can be that long. But if you have aggressive lymphomas, then within a year, you should have a treatment, or even earlier than that. So it depends on how aggressive the lymphoma is.
Indolent, that word reminds me of descriptive words I used to use in grade school essays to insult.
Wow, in grade school.
It's like just it's a description, right? Mga essay. Anyway, doctor, I'm sorry. Clarissa, who sent in her question, says thank you. Very informative show. She says thank you to you, doctor. And I
Thank
think now
you.
we're out of time. They're about to okay. Yeah, so we do have to go, doctor. I didn't even have to all I did was ask few questions. You gave us so much more than we expected. Thank you for being on the show. Please join us again to talk about anything you'd like that has to do with your practice, anything you're passionate about. Guys, and Mark and Micaela, thank you for booking Dr. Ginny with us today, and I'll be in touch, Doc. And thank you,
Thank you
folks.
for the invitation.
No, that was great. Thank you for being on the show. Okay, folks, see you again next time on Healthline with Makati Med. This has been Dr. 𝗛𝗵𝗹𝗁 de Leon, and I am Nicole Jacinto, your host. See you again next time. Bye-bye for now.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and comments of the hosts and guests